Good evening. I'm Dr. Paul Thierman, and I'm director of the Academy Library and Center for the History of Medicine and Public Health. On behalf of my co-organizer, Dr. Danielle Larac-Arena, I want to warmly welcome you to our discussion, Then and Now, Maternal Health, Maternal Mortality, and the Intersection with Race. We are glad that you've decided to join us as we explore this important topic. Dr. Larac-Arena will serve as the moderator of our discussion. Before I turn the podium over to her, I want to do three things. I want to give you a short introduction to the Academy and its Then and Now series. I want to lay out how this evening will go, and I want to provide an historic overview of the topic of maternal health in the United States, the then part of Then and Now. The New York Academy of Medicine was founded in 1847, 175 years ago. Today, NYAM is happy to take on the mantle of champions for health equity, tackling the barriers that prevent everyone from living a healthy life. The Academy Library dates from the very beginning of NYAM. We have since grown into one of the most significant collections in the history of medicine and public health in the country. We invite you to connect with us both digitally and in person. Now, as part of our 175th anniversary celebrations, the Academy Library is taking the lead in organizing events around the theme Then and Now, using the insights of history to shed light on issues of public health where the Academy has done and is doing significant work. In these events, we seek to pair historians and their distinctive take on events with policymakers, researchers, and people with lived experience. Tonight is the first such Then and Now event on maternal health, maternal mortality, and race. We plan 3 more such events over the course of the year. The next is on May 16th on drug policy and harm reduction, a significant and recurring interest of the Academy. We're also planning 2 further events for the fall, and you hope that you will join us for them. So this is how tonight is supposed to go. We envision this evening as a discussion. Each of the panelists will have about 5 minutes to sketch out their perspectives on this thorny issue. After that, we will all participate in the discussion for another half hour. You can share your perspectives as well as your questions in the chat section of Zoom. We will finish by 6:15. Now, let me offer my own 5 minutes. That is, I'm going to provide a historical overview of the topic of maternal health and maternal mortality, focusing on the presenting issue, the persistent racial disparity in outcomes. Let me make this historical claim. One of the main causes leading to these health disparities is the persistent othering by white society of Black women and their health. This leads to the growth of a blame narrative, whites blaming Blacks for disparate maternal health outcomes, to downplaying distinctly Black institutions around childbirth, and to Black disengagement with white medical institutions. I will touch on each of these in turn. First, it's important to realize that the nexus for the Black encounter with medicine in this country was economic, not compassionate. It was about money and not about healing. Up until 1865, the United States was a slave-based society. Enslavers brought doctors to attend to enslaved persons, first to attest to the physical condition of those persons in order to set sale prices and insurance valuations, and then to treat them in order to preserve their economic value. Medical innovation was pursued for the same reason, especially after 1808, when the United States banned further importation of enslaved persons. At the beginning, medicine served the interests of slave owners, and many Black people had little reason to believe that the medical profession had their interests at heart. Historically, the Black community had its own institutions for attending to maternal and infant health, that is, midwives. And I want to acknowledge here that Mimi Niles is on our panel, who with Michelle Drew wrote a wonderful article on this topic in the online journal, Nursing Clio. Up through the first part of the 20th century, midwives provided better birth outcomes than doctors or hospitals. That was the conclusion of NYAM's own study of maternal mortality in New York City in the early 1930s. The reasons have to do with low levels of physician training on childbirth, the slow emergence of the obstetrics specialty, and lax standards in hospitals. The results were very clear. Nonetheless, the medicalization of childbirth proceeded. NYAM's maternal mortality report itself called for greater physician supervision of midwives. And as Niles and Drew have shown, as midwives became regulated and higher training standards enforced, Black midwives were systematically excluded. And in the process, a significant Black institution was co-opted and reduced. Finally, overt racism played a part as well. Whites used racial stereotypes to blame disparate outcomes on Black women. In its 1940 report, The Health Situation of Negro Mothers and Babies in the United States, the US Children's Bureau labeled Black women as, quote, ignorant, non-compliant, and racially disposed to complications, in the words of historian Morgan Taylor. She sees this report as a modern touchpoint on the Black maternal blame narrative. She found that whites focused on the fact that Black prospective mothers seemed to ignore prenatal care, while not looking deeper into underlying reasons that hindered such care. Taylor found instances where whites dismissed Black women's active and informed advocacy for their own health in a way that can only be characterized as racial stereotyping. Historically, many whites have seen Black mothers as unconcerned about their pregnancies, setting up a dynamic for worse outcomes. So what strategies might we look for in the future? Some, and I'm thinking of historians Deirdre Cooper Owens, Charla Fett, say that change must come from the Black community. In their words, quote, reproductive justice and birthing justice must be attained by and for Black women systemically. Others, Ibram Kendi comes to mind, say that whites put in place the current racist structures, and they will stay in place until anti-racist whites and Blacks find the way and the will to change things. Now, which is true? I don't know. I don't have a crystal ball, but I do hope that I provided a historical frame for our discussion, and I look forward to hearing what our panelists have to say. I now pass the podium to Dr. Laraka Reyna. She is Senior Scholar in Residence at the New York Academy of Medicine, having served as President and Professor at SUNY Upstate Medical University. With Dr. Elizabeth Howell, she is co-founder of the NYAM Women's Health Research and Wellbeing Work Group, which has been instrumental in the creation of this event. Thank you.
Thank you so much, Dr. Thierman. It's such a pleasure to be with you and to be with over 100 participants in this current discussion. So I want to first acknowledge the members of the NYAM Community Program Advisory Board. Our conversations must always link back to community for various reasons, which I will exemplify later. I want to acknowledge the members of the work group, many of whom will be speaking today, but for those of you who are in the audience, thank you. I also want to thank Donna Fingerhut for her strong support of this work group. Thank you, Dr. Thierman, for setting the stage for our discussions. And I would like to see the slides, please. Thank you. Thank you, Dr. Thierman, for setting the stage for our discussions and beginning with the then. The historical facts and depiction of how a system built on slavery, oppression, with the complicity of physicians and medical societies existed and gave way to an unequal healthcare delivery system that permeates every aspect of medicine, even in the 21st century. And I am a physician and speak from that perspective. It calls upon us to put our voices and actions together to abolish inequitable systems and to rebuild. Next slide, please. I have nothing to disclose. Next slide. So I draw your attention to the timeline of US maternal mortality. And first, for definition. The definition as set by the National Centers for Health Statistics and also the World Health Organization is that maternal mortality is death while pregnant or within 42 days of the end of pregnancy, irrespective of the duration and site of pregnancy, from any causes related to or aggravated by the pregnancy or its management, but not from accidental or incidental causes. And please hold that thought. So as you heard, prior to the 1930s, back to the time of slavery, Black women's bodies were used as incubators of babies that would be born into slavery to perpetuate an unethical and immoral economic system. Medicine, specifically white physicians, were complicit in that arrangement. Then I bring you to the 1930s, okay, where the maternal mortality rate there is about 1,000 per 100,000 live births, okay? And I think the numbers are important because what we're talking about is the trend, the timeline of what's happened to women during this period. In the 1930s, interestingly, there was a focus on children's health and its accompanying implications for women's health during pregnancy. However, studies that directly addressed causation were not clear. And the Children's Bureau, as noted in the 1940s, reflected an opinion from historians that marked Black women, as noted just previously, inherently poor prospects for motherhood and the origin of the Black maternal blame narrative. Nonetheless, there were changes also for those physicians in the audience. I talk about the Flexner Report, which fundamentally changed medical education and medicalized health. And that was an important juncture in our healthcare history. Between the 1969, so you see in 1969, the next, and I'm sorry, I don't have a pointer, but in 1969 below, you see that we began to see decreases in maternal mortality up to the point of 1998. And again, I do want to focus that while healthcare improved, sanitation improved, a number of environmental conditions improved the status of children, the focus was not necessarily on the health of the mother, but the accompanying result was an improvement in maternal mortality, meaning fewer deaths. And however, I point to you, the health disparity ratio remained, where the Black-white disparity, where Black women were 2.3 to 5 times more likely to die during pregnancy. And the imbalance of the workforce is noted, and we'll have our next speaker speak to that, in the medicalization of birthing, which then focused on intensive interventions. For example, neonatal intensive care units really thrived during this period, and the development of OBGYN as a specialty, but de-emphasized the role of midwives. In a study by Seng, during this period, 1969 to 2018, you see 1998 to 2018, we begin to see an uptake of maternal mortality increasing, and the health disparities have not abated. And so monitoring disparities according to underlying social determinants became a focus in reducing maternal mortality as it gave rise to inequalities in social conditions and health risks. I don't have to tell you the current story, 2018, 2019, 2020 at the top line in Black non-Hispanic women. You see the rate is 55.3, which is almost 3 times that of our white non-Hispanic women of 19.1 and our Hispanic women of 18.2. However, during this time of pandemic, for all groups, maternal mortality increased. Next slide, please. We're going to go faster in the next few slides to comment on that. What we want to do in this conversation is to learn from history, to look very briefly at a summary of the governor's task force in rendering of priorities, the leadership in the 21st century that's going to be necessary, and also looking at the issues of pregnancy-associated causes that have to do more with violence during pregnancy, which increases, devil in the details in tackling the quality of care, and then perhaps some reflections in the future of whether or not we have lessons to learn from others. Next slide, please. Your 3 pre-reads, I hope you enjoyed them. I'm going to summarize them briefly. Owens, history matters. We need to not forget that what began both the healthcare system and the economic system in this country was based on oppression. And we are living the results of that currently. Newman, Henderson, and LaRocca-Arena, public health matters. I think COVID has taught us that. And lastly, an article shared by Elizabeth Howell from her experience at the University of Pennsylvania, Leadership Does Matter and May Make a Difference. Next slide. The Governance Task Force, I was fortunate to co-chair with a colleague who is on this panel, Wendy Wilcox. 3 points: data are important, education and training, and payment. And I hope you can download this from the website, from the internet, and take a look at the recommendations that you see listed here. We will discuss some of these. Next slide. So the New York Academy of Medicine has had a number of reports. In the 1930s, what we did not report on, although we noted the racial disparities, we did not attack inequities, structural racism, as fundamental to the solutions. And so our work group and the women and men who have joined us focus the New York Academy of Medicine on the health of women and children and community, women's rights, reproductive rights, ownership of their own bodies, children's rights, never divorce from their mothers, workforce priorities to address maternal mortality and to redistribute, retrain, increase the workforce that can respond effectively to the needs of women, and the role of science, policy, and yes, politics. Next slide, and my final slide is, let's not forget what the story is about. It is about our daughters and our sisters. This is my daughter with a newborn on the left, who was born during the pandemic, and her sister who's watching on. So let's focus our attention on what matters. And during these lightning rounds, and I will return with some concluding thoughts and challenges for us with the following question for you. What do we value in our society? So it's a pleasure to introduce our next speaker. And Dr. Mimi Niles is a founding member of the New York Academy of Medicine work group. She is an assistant professor and faculty fellow at the New York University Rory Myers College of Nursing. She is a theorist, an educator, researcher, and certified nurse midwife. Her work explores the potential of integrated models of midwifery care in creating health equity in historically disenfranchised community. Dr. Niles.
Thank you so much. I'm going to share my screen. So good evening, everyone. I'm Dr. Mimi Niles. I'm a midwife, a mother, an immigrant, and a midwifery care researcher at NYU. I'm really humbled to be here with you all in this illustrious panel as we do our diligence to honor Black Maternal Health Week. I've been invited to speak to you all on how midwifery care can be thought of as a strategy to build birth equity. It's important that we start with the overarching view of what midwifery care offers, as midwifery care is not just a profession, but also a philosophical approach to maternity care. It's based on the core understanding that health is not only a physical process, but also a cultural, social, spiritual, and communal process for most people. Pregnancy and birth in particular are held to be very sacred and dear in most cultures. And it's a process that warrants much care and attention to offering pregnant people and mothers and parents protection, guidance, and a deep sense of safety to support a very transformative life event. Today, midwives in the US attend around 10% of all births. In other countries that have a long and dedicated commitment to offering midwifery care as the standard of care, that number is closer to 50 to 70% of all births. Countries like Japan, Norway, and the UK. And notably, these countries also have significantly better birth outcomes. I believe that the lack of a robust and racially representative midwifery workforce in the US as the primary maternity care providers is one reason why we do so poorly compared to countries that are within our same economic bracket. The outcomes for midwives are stellar. When there's this false idea that there's not enough evidence for the expansion of midwifery, I have to wonder if we are just picking and choosing which evidence serves whose interest. Large systematic reviews show improved outcomes across the board: more spontaneous vaginal births, lower preterm birth rates, fewer miscarriages before 24 weeks, more VBACs, lower costs, and really critically greater sense of people feeling respected in their care. Midwives have proven to improve all of these outcomes. We also know that Black people are more likely to experience higher rates of cesareans, of inductions, of preterm birth, and low birth weight infants. So if we know there's an intervention that reduces these outcomes, that put one at greater risk for morbidity and mortality outcomes, that intervention is the reintegration of midwifery care as the primary point of access for maternity care. To me, that is the now in what we need. The question I usually get asked is, why these improved outcomes? And we know that this is because of the philosophical approach that I mentioned earlier. Midwives view the relationship of care as the driver for better outcomes. And that relationship ideally is built on deep listening, trusting, believing women, and responding to our clients is exactly what midwifery is built upon. We achieve this through an investment of time and resource, and that investment leads to the trust that leads to these better outcomes. There are three key markers of the midwifery care model, as I would define it. The model of care itself, as I've stated, is vital. It often gets lost in how we understand how midwifery care is distinct and separate from obstetrics and medicine. Of note, one of our core values is the continuity of care. That means the person is seeing the same provider through their pregnancy journey. And it's so key to our success in building that relationship and building that trust. And finally, I would offer that our approach is rooted in a strong feminist ethic of care. To me, that means philosophically, our practice is oriented to support a person's right to choose what they want for their care. In its ideal form, midwives can center and support bodily autonomy, their right to self-determination, and because we acknowledge that each person's care is shaped by a confluence of intersecting and personalized factors that deeply influence your healthcare experience. And I'd like to reflect a little bit on the then of midwifery, what has already been mentioned, but I really want to amplify and highlight this. The lack of birth equity now is shaped by the history of midwifery in the United States. Midwifery in the US has tangled roots, and we need to understand that context. When we take an ahistorical view in clinical care, it does a deep disservice to our understanding of what happened to maternity care and why we are where we are. As stated, for most of American history, midwives attended births. And I don't want to review what has already been reviewed, but I do want to state that one of the core central tenets of this midwifery workforce is that they were a community-based workforce. They were part of their community. They understood the needs, they understood the resources of the community, they understood the dynamics of the community. I would say the obliteration of the midwifery workforce was widespread. It was built on propaganda that claimed that midwives were uneducated, illiterate, dirty, and unsafe. And some of that rhetoric remains. I would say that to build birth equity means we begin to take a deeper look at the racist roots of healthcare and return power back to the people. That is what true integration of midwifery care would look like. I want to thank you all for having me and listening, and thank you to the New York Academy of Medicine to share this space to, again, honor Black Maternal Health Week, and that we all continue to commit ourselves to understand and protect and serve the families we care for to live their best and healthiest lives. Thank you.
Thank you so much, Dr. Niles, for bringing us back to what in fact is so important, our relationship and our communities. It's really my honor to introduce the next guest or the next speaker, Ms. Rosa Kulicki. She speaks from her experience with the birth of her 2 children, and you'll see this as a recurring theme. Many of us are mothers, grandmothers, And it's important that we listen to our own stories to understand. Her 2 pregnancies were deemed high risk by her clinicians. She joins us to share her story and to provide a message of hope. She delivered her children at Woodhall Medical Center in Bedford-Stuyvesant, Brooklyn. Ms. Gulicki.
Hi, good afternoon. Thank you for having me here. So I had 2 pregnancies. I was attended at Woodhall Hospital. So with both of my pregnancies, I was high risk. With my first pregnancy, I was honestly more unhealthy. I was struggling with high blood pressure. I was struggling with diabetes. Now with the second pregnancy, things were a little bit different. Now I would say they were different in the sense that I was healthier, my blood pressure was great, my sugar was controlled and everything. And one of the things that I feel like made this pregnancy not just more comfortable, but safer for me is that I had a very good relationship with my OB and my midwife. So at Woodhall, I was able to have Miss Jessica Lynn, I had Miss Hannah Lofton, Miss Helena Grant, my OB Dr. Zanat, and they were a very important part of my pregnancy. They were a great team. They were very supportive, and even though I was high risk with this pregnancy because of my history with my first pregnancy, I can tell you that I was very happy to be seen at Woodhall. I was very happy with the care that I received. They always made sure to answer my questions and to me. We always kept in contact. I feel like having a relationship with them and that communication, it allowed me to be in a comfortable place. You know, being high risk, you have all of these concerns, you have all of these worries, like, okay, you know, what if what happened in the first pregnancy happens again in the second? And that was not the case. They always made me feel like, you know what, this is your body, and, you know, you can make choices. You know, this is your body, but I want you to trust your body. I want you to trust this process and know that we're here for you, and anything that you need, you know, you're being taken care of. And I just want to give some advice to any moms. You know, you may be pregnant, or you may be considering pregnancy in the future, and you may have some underlying health issues, or, you know, these issues might pop up in the future, but just know that trust your body. You know, there's no reason why you shouldn't be comfortable at the place where you're being seen. You know, this is why the midwives are there. This is why all this information is being shared. Also, you know, just to give you a sense of understanding of how things work, and just know that everything is going to be okay, especially now we're still kind of dealing with this pandemic, but, you know, there's a lot of worries and concerns, and just know that as a mom, you know, I can understand you and I can relate to you, and the same worries that I had, you might have them now, but just educate yourselves. That's the most important thing that we can do. And even being here in this webinar is giving us that opportunity to learn and educate ourselves in this field. Thank you for having me here.
Thank you so much, Rosa Gulicki, for sharing your story. And again, one of the things we'd like to have the audience, and now I see that we are 159 strong, is to work together to center the lives of women and children, their families, the community in our discussions. So it's my pleasure to introduce now Dr. Tony Stern. Dr. Stern is a board-certified obstetrician gynecologist and a founding member of the New York Academy of Medicine Women Health Research and Wellbeing Work Group. She serves as the vice chair for quality and diversity and equity and inclusion, and a chief patient experience officer, the Raquel and Jamie Galinsky Department of Obstetrics and Gynecology and Reproductive Science at the Mount Sinai Health System, and the Senior Associate Dean for Gender Equity in Clinical Affairs at the Icahn School of Medicine at Mount Sinai. Dr. Stern.
Thank you so much, Dr. LaRoccarina. It's such an honor and a privilege to be with you today. I'm going to be presenting on behalf of my colleagues, Drs. Van Zulian, Drs. Flores, and Dr. Newman. And our topic today is working towards solutions for maternal and child health inequities in the COVID-19 era and the remaining challenges in telehealth access and use. Next slide. So we're just going to provide a brief background of the current state, the utilization of telehealth, and considerations for future use and optimization of care. Next slide. As we recognize Black Maternal Health Week, it's important to just highlight what we've seen in the last 2 years, the increased focus on Black birthing women and the deaths related to maternal mortality, and very importantly, also severe maternal morbidity. So to the right, you can see for 2020 maternal mortality rates by race and Hispanic origin. You see that for Black women, it continues to increase and overall increasing as well. Next slide. So this is just a slide that I think is important. This is CDC data related to COVID, and it's not specific to OBGYN, but just highlights the disparities by race and ethnicity for patients for hospitalizations and deaths during COVID. And so again, we see for our American Indian and Alaska Native, our Black and our Hispanic birthing people, significant disparities with regard to those hospitalizations and deaths. Next slide. So as we focus on how we can utilize the resources of telehealth and telemedicine, we have to be very intentional in evaluating the social determinants of health. All patients do not come to us with the same resources, and there are significant barriers. So just wanted to highlight these areas: education and quality, the neighborhood and built environment, and specific social and community context, and economic stability. Next slide. So just going to go over some utilization data related to telehealth during COVID-19, and really what do our patients have on their journey, as our goal is person-centered care. Next slide. So here we see, when we look at the 4 telehealth providers nationally that provide the largest amount of service, we see that when we look from 2019 through 2020, significant decreases as we move into COVID pandemic time, but also significant uptake for our utilization of telehealth. So we see here March 27, 2020, that's the CARES Act enacted. And what we find is that at the same time that we're utilizing telehealth and telemedicine, we're seeing that for our Black and Hispanic adults, if you look to the right, you see that they're less likely than white adults to have a traditional computer, to have home broadband. And so we're seeing this disparity in what resources can be made available to these communities. Next slide. So I just wanted to give an overview. Telehealth and telemedicine, often interchangeable, but for insurers, often it's important to highlight the difference. Telemedicine, more of the virtual visits, the two-way synchronous, and then telehealth, the global asynchronous patient-provider interactions, home-based monitoring, et cetera. Next slide. So when we look at OBGYN specifically, we can see what are the services that are provided. We have, of course, the pregnant person at the center of care, as it should be, and then we see virtual prenatal visits, at-home monitoring, consultations, but also lactation support, virtual visits, and other types of communication throughout the continuum of care, from prenatal, postpartum, and then inter-pregnancy care. Next slide. So this is just an overview again, looking at the hand. This shows us what we saw traditionally prior to COVID, and then now what we see after COVID with utilization. So we see that the computer represents the way that we can intersect telehealth and telemedicine into the care that we provide to our women. Next slide. So what are our considerations for future use? Next slide. We know that as we have to close the disparities gap related to telehealth and telemedicine, we need policy changes at the federal level. We need expansion of the care delivery system. We need to enhance the growth and diversity of our perinatal workforce, and we need data-driven action through the equity lens. We need to support also our community-based groups and address issues that intersect with maternal health. Next slide. Just sharing resources, and thank you.
Thank you, Dr. Stern. I also wanted to acknowledge that Dr. Stern's presentation was supported with the involvement of Dr. Roseanne Flores, a member of the NYAM work group, who is Associate Professor of Psychology at Hunter and CUNY Graduate Center. And you'll see all of the panelists in a few minutes when we finish. Dr. Connie Newman, who is a founding member also of the work group and adjunct professor of medicine at NYU, and also served as the 2018-2019 president of the American Academy, the American Medical Women's Association, as well as Dr. Rose Maria Van Zulen, who comes via Miami. And so this is a national effort, is also a founding member and an associate professor of professional practice, Department of Medical Education, Lillis School of Medicine at the University of Miami. So it's my pleasure now to introduce Dr. Wendy Wilcox, who will round off our discussions, and I will have some concluding remarks. So Dr. Wilcox serves as the Chief Women's Health Service Officer, New York City Health and Hospital System, a new role that organizes all of women's health offerings under one office for HH. Dr. Wilcox works with the Women's Health Service Clinical Council to plan, organize, and develop policies related to obstetrics, gynecology, well woman care, maternal mortality, maternal morbidity, documentation, and revenue capture and growth. She's a former chair and chief of obstetrics and gynecology at New York City Health and HH. I'm used to saying Health and Hospital Corporation from the past, and Kings County. So it's a pleasure to have her here, and she will, and obviously we congratulate her on her new position.
Oh, thank you so much, Dr. LaRocca-Rena. I'd like to thank you and the NYAM team for inviting me to be part of this very august panel in honor of Black Maternal Health Week. And as a Black obstetrician, gynecologist, physician, and a mother of 2 adult children, I am just really honored to be a part of today's program and to talk about this incredibly important topic. I'm just going to be sharing with you today, and I'm going to start at the 50,000 foot view and then come down to what we're doing on a perhaps hospital system level about potential solutions. Of course, we know that this is not an exhaustive list, but as you know, in addition to the other panelists, I'm just going to be sharing some of our responses to this problem. I do not have any financial relationships to disclose. And first, I want to talk about HR 959, which is the Black Maternal Health Momnibus Act. Now, you may have heard that this act passed, and in fact, a portion of this act did pass for veterans, which is incredibly important. However, the bill was passed by the House, but it lies stymied and delayed in the Senate, as many things do. And what we really need is for this bill to pass for everyone. And so what this bill would do is direct multi-agency efforts to improve maternal health, particularly among racial and ethnic minority groups. Veterans, as I said, have already passed, and other vulnerable populations. It also addresses maternal health issues due to COVID-19. And the whole point of this is to try to address social determinants of health, extend WIC to 24 months, grow and diversify the maternal health workforce. You heard Dr. Niles talk about how important it is to address the diversity within our midwifery workforce. Newsflash, we need to do that with all aspects of our healthcare teams, including our physicians. We need to increase access to maternity care. And this really calls for HHS to encourage innovation in payment models so that all aspects of care, including, thank you so much, including psychologists and social work and our care navigators, so that all of that can be covered, because as you can see, that is also very important to the care we deliver. And it would encourage data collection and also look specifically at getting maternity care for incarcerated population. Included in this is improving vaccination rates for COVID-19. Next slide, please. So we all remember the very public story of Serena Williams And were she not the person who she is, she may have not basically been here to tell her story. And she had to literally go out and yell from the rafters that she was experiencing a pulmonary embolus, which is a clot in her lungs. And she had experienced this before, so she knew what it felt like and what it was. But we don't want that to be the norm. So the CDC has something called Hear Her campaign, and it really is encouraging providers to listen to our patients. And that may not sound like something that's rocket science or something, but it is incredibly important. And it is being drilled down to all aspects of our care teams that we must listen to our patients. Incredibly important message. Next slide, please. We just had the passing of the New York State budget, and so thrilled that in that budget, there's some important legislation and provisions for maternal and women's health. There's a provision, as you heard Dr. Stern talking about telehealth payment models and parity. And so we're really looking at increasing access through telehealth services, and this will be provided for in the budget, at least for 2 years. And there's an extension of Medicaid coverage, which you heard Dr. LaRocca talk about in the beginning, from the Maternal Mortality Review Board release of the report from the New York State Department of Health. And that was one of the recommendations from that group, to extend Medicaid coverage for 1 full year from the end of pregnancy. And that has been included in this budget. Next slide, please. So now I'm going to drill down, and this is something that has been tried across the in certain hospitals, and certainly in New York City Health and Hospitals, we're doing this. And this really is improving high-risk obstetric outcomes by focusing on women who may face challenges, either due to clinical issues, socioeconomic issues, challenges, as well as behavioral health challenges. And we're really looking for integrated care models where we can help patients to access all of the care that they need and get those extra touches to get them through a healthy pregnancy and delivery. Next slide, please. And 321 Impact is another integrated model where we are integrating women's health, pediatrics, as well as behavioral health, and looking at how to continue the health and well-being for patients who've delivered well past that 6-week postpartum period. Really, it's looking at a care prevention model to prevent 2-generational trauma and continue the health and mental health provision of services for the parent by having mental health services provided in the women's health sphere. Next slide, please. And with that, I'll stop. Thank you.
Thank you, Dr. Wilcox, and thank you, the audience. I see we are still holding strong at more than 150 of you. And we are sorry that we're not able to be face-to-face for these discussions, but I thank my colleagues for at least touching upon the key points. I want to have my slides, the summary slides, please. I ended with this slide, and many of us can put slides up. This happens to be my daughter and her 2 children. So we are speaking from the perspective of families, communities, but and to tell you of the progress we've made, but what else needs to happen in the future. So we are talking about then, now, but also hopeful messages as given to us by Ms. Galicki, that the outcomes for pregnancy must be better and can be a joyous event. Next slide. So I asked you to think about this following question at the beginning. What do we value? What do we value now, and what do we value in our future? We know from discussions of slavery and oppression and systematic racism and structural racism that in fact we did not value each of us. But our values, if we begin here, and this slide is going to show you by this arrow, the green arrow here, is where we're really at the point of looking at processes. Okay, but let me begin with how are we structured as a society? What are our values? Are they equity? Are they community? Are they fairness? Do we value women and children in this community and populations in general and our culture? What are our laws? We don't have the time to discuss the number of anti-discrimination and civil rights efforts in the 60s and 70s and way before that, of course. The topic of structural racism has come in the last 10 decade or so in terms of understanding that unless we look upstream, we will not be able to affect the processes that we are talking about, which is individual care of women and children. Anti-sexism, child rights, reproductive rights, healthcare as a human right. We have not established that yet in this country. We have the Affordable Care Act that went from discussion under the Obama administration of universal health care to a public option, and then battled for the Affordable Care Act. And you heard from Dr. Stern and Dr. Wilcox about the Momnibus that tries to extend coverage, the perinatal period and the postpartum period, because we know those kinds of interventions are evidence-based and will reduce maternal mortality and also infant mortality. And yet we have fragmented systems. So will we reach the point of healthcare as a human right? And of course we know, devil in the details, what are the resource allocations and finances? So I point to you, what are our processes? So some of you will recognize this: structure, process, and outcomes. What are our processes? We have conflicted leadership. Now, there is a question on the chat about whether or not there have been conversations with hospital administrators. Very key question about the possible conflicts when we say to our hospitals, you must fill your beds. Length of stay matters, and rapidity with which you discharge people matter, and we have not established a continuum of care. Healthcare financing matters, as you just heard, extension of WIC, postpartum for 24 months. Lack of organizational justice in partnership with communities. I don't have to tell this group about that, that unless we are listening to the communities, and I have to give you a note, nonprofit organizations are actually must monitor their lobbying to be compliant and stay non-profit. There is no such limit for you as community members to voice your support for the kinds of measures that we are talking about. Failure to leverage or advance technology, Dr. Stern mentioned, use of telehealth. Do we have broadband access for all of our communities? Can we do this in the way that facilitates care, in the way that women want their care or birthing individuals want their care? We should be able to do that in the 21st century. The financing that leads to fragmented care, lack of equity, embedded QI and research, and self-interested workforce and incentives. We've heard that around the world, there are different models, right? That reserve obstetricians for the most high risk, and that there is a team science and team-based care. There was a question about whether someone could choose to be followed by a midwife. Well, in fact, other countries have answered that question to say it's actually more economical and the outcomes are better when you begin with midwifery. And of course you do risk stratification to understand what different women might need in their care. And lastly, what are our outcomes? You've heard, we have persistent health disparities. The health disparity ratio in 2020 is nearly 3 times between Black women and white women. Again, this is a binary analysis. We know that other groups are also affected by poor outcomes. And the worst, the maternal mortality outcomes in the United States as compared to other high-income countries. So we know we could do better. So next slide. So what do we value? Well, if we say we look upstream, then we must restructure We must restructure, abolish the current healthcare system that sacrifices quality for profit. We must tackle the payment structures. And I know this is a hard battle. So it's going to require organizational efforts to get there. The role of academic medical centers and academic health centers in compensation models, and partner with communities to develop socially accountable educational healthcare systems. If we do that, it will require, and Liz Howell and I discussed this, leadership that is bold and fearless, equitable healthcare financing, organizational justice, making our technology and our advances available to all, comprehensiveness, primary prevention. We tend to tackle in medicalization of care problems at the end. Serena Williams' story about having a PE should not have been that the patient needed to be her only advocate. That should have been part of the continuity of care. And then diverse and increased supply. And there are solutions offered by others to increase the number of midwives and equitable payment, as well as the number of diverse obstetrician and gynecologists, because we know that there is a lack of representation also in the field of medicine. So what can we look to our outcomes? An elimination of health disparities, quality outcomes for all, respect for the individual, respect for culture, a message of hope, as was given by Rosa Galicki. We open this up for your discussion, your challenges, but we ask you a particular challenge. What do we value, and how do we partner with you to be able to affect the changes so that in 100 years, we are not having the same conversations about disparities in care and maternal mortality? So we open this up for your questions, and I will be monitoring the chat. So I am going to go as quickly as I can. I see that there is a question that says that Dr. Wilcox mentioned intergenerational trauma. Can she discuss this a bit more, please?
So there are studies that show when the parent or the pregnant person is traumatized, that also can affect the cognitive and developmental abilities of her newborn and growing into a child. We currently have a study that is studying this up until the child is 3 years old. And the provision of services during the prenatal period, such as behavioral health services and or other supports, can help to address and prevent this trauma, which will then later on go to affect the child's development and the whole family. So this is a pilot program we have at New York City Health and Hospitals. I know there are other such programs going on at other health systems, but we're really starting to look at how do we prevent these situations from happening and optimize the healthy growth of children. And a lot of different, a lot of research has shown that it starts with the parent.
As I look at the questions that are coming, I'd invite the members of the panel who would like additional comments, any additional comments as I sort through these questions, if any of you would like to add some comments based on the presentations thus far. Okay.
So I will add a comment on, it's wonderful to hear that, that New York is expanding some of the coverage, but as all of you know, Medicaid is state run, right? And so there are no guarantees that many of the other states will, enact a similar legislation. And this is, I think, one of the challenges, because we know that almost half of all births are supported by Medicaid. And we have a lot more work to do in other states.
Thank you, Dr. Zulin, because in fact, it points to, if you look upstream, I mean, we have a system that is trying to move forward and improve outcomes, but without national policies that equalize those benefits, we will be always playing catch up. So thank you for those. One comment is from an individual: thanks for an important session with good timing MCHB's State Maternal Health Innovation and Data Capacity Program was posted today and due June 13th to fund 9 states for $1 million per year for 5 years starting in September to reduce maternal mortality. So, and the person goes on to say that 9 states have been funded in early cohort. So again, the need for state advocacy as well as national advocacy to make sure that the solutions we know are implemented. We use best practices, evidence-based practice, and we scale it up. So thank you for that comment. There was a comment which I think can be asked of a question to Dr. Niles with respect to the person asked, what's the difference between doulas and midwives?
That is a good question. I think there's a lot of confusion in the ethers around the differences between midwives and doulas, and there is a big difference. So midwives are independent, licensed clinical practitioners of care. Particularly in New York, we have a pretty wide scope of practice. So you can get all of your pregnancy, prenatal, labor, birth, postpartum care with a midwife, dependent on what your risk conditions are at the time of your pregnancy journey. So they are independent licensed clinicians. Doulas, on the other hand, provide emotional, social, physical support for pregnant people and their families. They're really a wonderful addition to your support team that can also include your family members. They just have a little bit of additional training around what some of the common discomforts of pregnancy can be, how to support your mental health, how to support your social health, but very, very distinct and different. Both can add great quality to the pregnancy care experience, but it's really important to understand and be clear on what the distinction is.
Thank you. I'm going to read another question. Thank you for your presentations, Dr. Niles, Dr. Stern, and Dr. Wilcox. I'd like to ask, as we know that midwifery care is crucial to improving care and reducing maternal mortality rates, what provisions are included specifically in the Momnibus bill that would improve access to midwifery care, expand midwifery workforce, and help integrate midwifery care into the mainstream? And I invite both Dr. Wilcox, Stern, and Dr. Niles to respond.
I will say with the Momnibus, the full package Momnibus, there are provisions in there in terms of expanded access to educational pathways to train more midwives. That's probably one of the most direct way that the full Momnibus, as it was fully envisioned, provided a funding stream for midwifery education, because we know we are a limited workforce. We desperately need to grow the midwifery workforce in the United States. If we're only attending 10% of births, it's not enough. And then the other way I would say, and I'll pass it to my colleagues too, is specific funding for community-based initiatives. And that could look like midwifery-led birth centers could also gain access to some of those funding streams. So those are the two ways I would say the Momnibus addresses this, but this bigger issue of integration, which is really my passion project, is not directly addressed in the Momnibus package.
Dr. Wilcox, would you like to comment?
I'd just like to add that I don't think the educational component of that is to be taken lightly. We really need to encourage people of color, BIPOC people, to enter into healthcare. There's study after study after study showing that patients are more receptive to their care when it's provided by someone who looks like them. We have a system right now that is perfectly designed for the results we are achieving, right? We have less than 10% of our healthcare workforce are BIPOC people. And so we need to increase midwives, and midwifery training, I just want to say, involves school certification, correct? Mimi, I don't know if you want to talk more about the educational requirements by midwives to become fully licensed credentials providers, but it's not to be taken lightly. And so, providing these educational pathways, whether it's through scholarship, whether it's through active, what do I want to say, recruitment, going to our historically Black colleges and universities. It's got to be multiple different pathways, because we have a big hole right now to try to fill.
Thank you. Thank you. I actually was just thinking that we have not used the word implicit bias and overt bias a lot in our discussions, but there is a question relevant to this. It says, how can I help my medical students and nurses, PAs, and MAs address their racism and their bias in their medical education and in biomedical sciences? Invite any member of the panel to respond to this.
Thank you.
I'll start.
Oh, go ahead.
Jen.
No, go ahead, Rose.
So I am at a medical school. We are one of the most diverse private medical schools in the country, down in Florida at Miami. We have implemented a number of different initiatives, Racial Justice Task Force, which is taking a very critical look with the help of our medical students. They are very much involved in our own self-assessment of all of the different educational elements. So we are looking at the cases that students read for their case discussions. We're looking at our standardized patient program. The students have actually emailed me about wording that I have in some of my study material that they thought could be improved. So I think it's really critical that we involve the learners in this process, because they are often maybe a little bit reluctant to speak up. We have also, as part of our overall mission, implemented a lot of different training from both the American Association for Medical Colleges, as well as others that have come in and done implicit bias training. But this has to be an ongoing process. This cannot be a one-time, review or experience. This needs to be, the eyes need to be open at all times on this.
Thank you. Dr. Stern?
I completely agree. Thank you, Dr. Van Zulian. I also just wanted to highlight that, when we're rounding in real time, we need to be very mindful of how we're referring to patients. Very frequently, evidence has shown that often our patients of color and racial and ethnic minorities are referred to as non-compliant. And, we really don't look into why that could be. When we talk about the social determinants of health, frequently we see that, okay, if a patient's not presenting for a visit, is it because they only have one bus route to get to the visit, and what's their access? So I just think it's so important. And when we evaluate our quality metrics, we have to be evaluating that as well. And I think that so often what happens is that we have all of these standard quality metrics and we have all of our identified areas of focus, but we do need to have that different lens.
So I want to add in too.
Please.
No, I'm going to do it from a biomedical research side, because I think our research side is important as well. And I think that when we're designing our research and our studies and how we do that work and who we include as participants in the studies, and also, again, when we're doing our randomized clinical trials, what does that look like? Who are these folks? That's going to influence also the training of the medical students, right? Because that's the work that they're reading. That's the things that they have their hands on. So I think it's the research, because that also impacts the policy, right? That's also the folks who are in the policy arena. They're going to pick up those papers. That's the stuff they read. That's what they get. That's the brief they have. So I think we also have to focus on that as well. And that also is impacted by the bias, because who are the people who are actually accepting our publications, and how do they get out into the field? So I think we need to really look at that as well.
Yeah, and I'd like to add a historical take on this also. I think there are literally decades and centuries of people working in these fields, and it's somewhat dangerous to hold them up as, quote, role models, but I think their stories need to be told. I mean, the one thing I would like to hear more a little bit about is the listening emphasis that was presented earlier. Listening to other people is remarkably transformative, and hearing other people's stories is remarkably transformative as well.
Yeah, thank you for that comment. I'm sorry, Dr. Wilcox, did you want to make a comment?
May I add something, please? I don't want to lose the aspect of intentionality and the intentionality of our leadership to create a diverse workforce. And that being said, I do have to mention a tweet that just went out from our CEO, Mitch Katz, that said, Metropolitan, Harlem, Queens, and Lincoln are part of a list of 50 most racially inclusive hospitals in America. And so when you have a health system that is intentional about who it's hiring and the policies it's enacted, it goes a long way. And that says a lot, not only for the system, but for the patients that we serve.
Thank you for sharing that tweet.
Can I add, because we're here at NYAM, I mean, the history of healthcare, the history of medicine, the history of obstetrics has to be taught. It has to be taught, and not just to physicians, to nurses, to midwives, to PAs, to dentists. I mean, the statue of J. Marion Sims was in front of NYAM, and because of the work by researchers and historians like Deidre Cooper Owens and Harriet Washington, we know that Black women were the subject of medical experimentation as well, Puerto Rican women as well. And so I think we need to start really being radical in the way we educate healthcare providers, so that if they don't start from that radical place, that they are, not only are they healthcare providers, but they are justice warriors, this is not going to change, because it's so woven into every single part of the system, the education, the training, the models, the funding, the payments. And it's really hard to get out from under that because it's so complex and twisted.
It's complex, but I just want to insert here that the reason that Dr. Thierman and I thought that we should partner in this is to understand that medical education, we do have an associate dean, Dr. Stern, at a table, and I have been president of a health science university that does have deans who provide leadership and chairs and division directors and administrators who provide leadership. And yet in the curriculum, there is absent the history that Dr. Niles, you talk about, absent the history of the Flexner Report that eliminated a number of historically Black colleges, absent the history of what happened to midwifery in this country when conflict of interest entered into not only the medicalization of birthing, but also the payment structures that determine that. So again, thank you for saying that. And some of us have used terms such as abolish and dismantle the current system. The problem is you have to fly the ship as you're going. And so we really need to be thoughtful in our organizational efforts. I would say that we have representation here, Dr. Wilcox, HH, 11 public hospitals, but even greater integration of the workforce and integration so that payment does not factor. Yes, we have to pay for care, but payment does not factor in how care is delivered. Dr. Van Zulen, you wanted to say something.
No, I just wanted to comment also on a question that was raised in the chat about should we incorporate midwifery as part of the education to all students and residents. And I can tell you that at a medical student level, in most programs, there's a really big challenge for students to even be part of any delivery. And to be part of that, we have a required rotation, but the residents need to meet certain metrics, which is already a challenge as well. So I can tell you the average doctor gets very limited training. I'm a big fan of interprofessional education, right, where students learn from and with other disciplines. So I think this is an excellent comment, because how wonderful would it be that they recognize the value of what midwifery can offer if they spend a day, just even to start with, spend a day with that professional and see what kind of training and what experience they have. And then it's more likely that we can expand the models of care when those trainees who are going to be our physicians, right, recognize that this is other options out there.
Yeah, and I think if you don't see normal birth, you don't know what normal looks like, right? So in other countries, I don't know where you're from, Dr. Van Zulen, but in other countries,
the Netherlands,
yeah, they send their medical students out with the midwives to do community visits, to do home visits, to attend home births, so that they can see that birth is normal. Because if you don't see that, you don't believe it. And then
that's how I came into this world.
Yes,
Dr. Niles.
every birth becomes a problem to be solved instead of a process to be held and to be supported.
And actually, although, and I do want to get to some of the other questions, the idea of service learning has entered residency training a lot, and longitudinal care, so medical students can follow a family over the course of several years. So continuum of care and service learning, where you actually get experience in community-based care, is going to be vital. Those thoughts are there. What's missing actually, though, is at the national level to move that and to scale it so that you're not dependent on grants or very different policies at state level. So those are our challenges. Now, I do want to address a couple more questions we have. I'm watching the time. We have 4 minutes left. And one question had to do with home births. So it says the latest CDC numbers show a significant rise in community birth choices among Black pregnant people, meaning a rise in home birth and birth-centered births. Can you speak of the importance of birth setting choices in maternity care? Okay, we alluded to it a little bit during the discussion, but would anyone like to take that question?
I mean, I feel like I would like to take the question. I could probably run with it for more than 4 minutes, but I'll keep my comments tight. I think, again, we need to start thinking about not just the provider, right? But the provider and the location of birth, the birth setting. NASM produced an amazing report on birth settings in America. This is a huge factor in the United States, that 98% of births happen essentially on a surgical unit, right? And so we have these rising rates of cesareans because you're on a surgical unit. So what does normal birth look like? There are people who qualify for birth outside of the hospital in community settings. That could change. That is a game changer, right? To really provide community-centered care by community-trained midwives, to provide care in people's homes and in community birth centers. This is a possibility, but like you keep alluding to, that's going to take muscle. That's going to take funding muscle. Right now we have inequitable pay reimbursement for midwives, inequitable pay reimbursement for birth center births. That same study that looked at maternity medical homes also looked at birth centers, and they're improved outcomes, lower preterm birth rates, lower cesarean rates, lower costs, greater satisfaction. So what is it going to take? Because we keep talking about evidence, what is it going to take to actually implement the evidence is going to be a wide, the net is wide. It's going to take not just the funding changes, but I think there's going to have to be a cultural shift within medicine that has to happen that we just don't talk about enough.
You mentioned something very important about choices. I would love to hear from Rosa, one of our panelists, about choices. Yeah. How important that is.
Rosa will give you a few. Again, I will promise the audience that we will continue this conversation. In an hour and 15 minutes, we can't do that. Rosa, I would like to hear your voice, and then I will sum up.
No problem. Yeah. So just to make it really quick, one of the things that I said that I liked about this pregnancy and even my past one is that I had a choice. And I feel like sometimes because people don't understand that they do have a choice when it comes to things, I feel like sometimes they settle for what's being said to them. But once again, I make it very clear that it's very important for us to educate ourselves, because when we educate ourselves and we know what our rights are, honestly, no one can take that away from you. And once you know what you have a right to do, they can't mess with that.
Okay, so again, thank you to the audience. And again, I wish we were in person so that we could continue the conversation. This is just the beginning. I think Dr. Niles stated it well, that we have a challenge. We know the data, although data are important, and it was one of the top priorities from the governor's task force. We cannot continue to repeat the data, repeat the fact that there are health disparities, and do nothing. The financing of care drives outcomes. So yes, we can have the science here, right? And you can have the policies, but without political will and activism, which is not usually driven, I'm a physician, I can say this, not usually driven by the medical folks. It is driven by community action. So call to action, and the reason we're asking your support is because we are scientists, we are educators, but we cannot do it without community activism, and we need to partner with you effectively. I will give the last word to Dr. Thierman, since he began opening up to understand our history, not to repeat the mistakes of history.
Thank you.
I give you the last word.
Thank you. I endorse everything you say. And I just wanted to go back to one of the earlier things you said about when will health be considered a universal human right. And the thing is, we're there already, at least in paper. Both the World Health Organization and the United Nations have that as part of their charters. And I guess the question is that can be a stick to drive with. That can be saying, this is what we say we're going to do, let's do it.
Well, exactly. Universal health and healthcare is a human right, and we are citizens of the world, and we must drive that agenda, but it will not be without major effort. I thank you.
Yes.
I see that we still have more than 100 folks who are talking with us. Please know that we could not cover everything, but we thank you for your participation, and we really invite you to continue to inform us and to keep us on our toes with respect to what needs to happen from a great institution such as the New York Academy of Medicine. Thank you very much, and we will end there, and we will save the chat. And if they're, and try to respond in a conversation on the web as well, okay? So not on the web, on postings. And the slides will be posted, correct, Dr. Thierman?
Yes, they will be.
Very good. Thank you so much, and have a good evening.
Thank you. Take care all.